Hi, so I'll be presenting a case titled Imaging Findings in a Case of Spontaneous Resolution of Syringomyelia. I originally gave this presentation at the ACC Research Agenda Conference in New Orleans in March of 2023. Before I start, I just want to extend some thanks to my co-authors, Angelica Turner and Dr. Laura Tollefson. All of us are from DeVille University in Buffalo, New York. We have no conflicts of interest to report. Our objective is to describe imaging findings of a patient that had a spontaneous syrinx resolution between the years of 2013 and 2021. So for our case, we have a 33-year-old male that submitted serial imaging to a chiropractic radiologist, or a DAC-BAR. They had a history of occupational traumatic motor vehicle accident in 2013. The patient was working in a tractor, grooming snowmobile trails, and they went into a ditch. When they went into a ditch, the patient describes themselves being whipped around the cabin, and they actually went through the window on their left side and were unconscious for what they estimated to be 10 minutes. At the emergency department, a CT of the cervical spine was performed and read as normal. The patient was released with a diagnosis of a concussion and was not given any specific discharge instructions. So the patient later on that night continued to feel very foggy, still had a lot of neck pain, and actually went back to the emergency room at this point, drove themselves to the emergency room, and drove home also. And when they got to the emergency room again this time, second time that day, they were actually finally given specific instructions to avoid driving and other things like to rest in a dark room. So what you see on screen now is the initial CT from 2013. This is the day of the incident. At the end of the arrow, you can see a region of hypoattenuation that is between the C5 and C7 cervical levels. We can see it on both the sagittal and coronal views. Retrospectively, we know that this is the location we will later see the syrinx on MRI. The patient continued to experience suboccipital neck pain. There was pain referral with that. Experienced headache and dizziness with postural changes. He described his pain as being 7 out of 10, and also denied alteration in extremity sensation or function. He also continued to experience brain fog and had wraparound headaches. The patient did undergo chiropractic and physical therapy care and did have minor improvements in symptoms, but he was still having issues driving vehicles such as a skid loader that he used in his daily work. In 2016, a follow-up MRI was performed. So on our left, we have a sagittal T2, and on the right, we have an axial medic at C6. An axial medic is just foiled gradient echo. So what you will see between the vertebral levels of C5 and C7 is a 26 by 4 by 5 millimeter enlargement within the cervical cord itself. This contains a high intensity and is consistent with fluid signal. This is the syrinx, and it also is, again, the same location where we see the hypoattenuation on the initial CT. So then the patient continued experiencing intermittent symptoms that would come and go, pursued further chiropractic and physical therapy treatment as needed. 2019, we have another MRI. So again, on our left, we have a sagittal T2, and on the right, we have an axial medic at 6. As you can see here, the syrinx shows no significant change in morphology or location. It's almost an identical picture. 2021, the patient began to note improvement in symptoms. He was also having difficulties acquiring life insurance due to the syrinx. These two factors led to a new MRI to evaluate changes. Now, here's our 2021 sagittal MRIs. On our left is a 2, and on the right is a stir. As you can see, the syrinx is no longer present in the cervical cord. There has been spontaneous and complete resolution of the condition. This is again a further comparison with our sagittal T2 from 2019 and our sagittal STIR from 2021 on the right. The syrinx is gone. So, a syringomyelia or syrinx is a fluid-filled dilatation of the central canal, commonly located in the cervical or thoracic cord. Pathophysiology of a syrinx is believed to be related to changes in CSF flow and disruption of the blood cord barrier that comes from fluid pressure gradient changes across this barrier. They're typically associated with a, quote, cape and glove or shawl-like loss of pain and temperature sensation, but they can also have muscle weakness, atrophy, and spasticity of the upper extremity if they are large enough. This primarily comes from disruption of spinal tracts, such as specifically Lissauer's tract of the spinothalamic tract, but it can also compress the lateral columns, such as the corticospinal tract. Syrinx are commonly associated with trauma, Chiari malformation, and other hindbrain abnormalities. For our patient, the only risk factor of syrinx development they exhibited was the traumatic accident, but there are some caveats. Syrinx formation can take weeks to years post-trauma. You remember the CT the day of, it was already there. Our patient also had 5 millimeters of cerebellar ectopia, but that does not meet the diagnostic standard of a type 1 Chiari malformation, and the risk factors for cerebellar ectopia are essentially identical to that of a syrinx. Another thing to consider, we had no advanced imaging prior to the incident, so we actually don't know if the syrinx was present prior to the incident. Therefore, taking all of this into account, we think the etiology of the case is most likely idiopathic. So, spontaneous resolution of a syrinx is incredibly rare, and we found only approximately 39 previous cases ever documented in the literature. Of those cases, only 1/3 experienced complete resolution, and some actually ended up experiencing a return of the syrinx at a later time. For a syrinx without progressive neurological symptoms, regular monitoring and symptom modulation may be the preferred treatment plan within the chiropractic clinic, but it is important to consult a neurosurgeon for further evaluation and co-management of the condition, even if there is not progressive neurological symptoms. Resolution of this patient's syrinx cannot be linked to any specific intervention and should not be considered a likely outcome for any patient.